Hi everybody, and welcome to our module on gram-negative rods. This is our algorithm for identification of gram-negative bacteria, and what we're going to do in this module is talk about the rods. The rods are differentiated by whether or not they ferment lactose, and then they're further differentiated by whether they are fast or slow fermenters and whether they are oxidase positive or negative. And so we're going to talk about all of these bacteria on this portion of the slide in this module now. First, let me mention a couple of general points about gram-negative rods. Most are in the family of enterobacteria, and this means that many of them are normal GI flora, especially in the colon. They can cause lots of diseases, but some common diseases caused by gram-negative rods are diarrhea illnesses and urinary tract infections. And most gram-negative rods are difficult to treat because they're resistant to a lot of antibiotics. In particular, most gram-negative rods are resistant to penicillin and vancomycin. Their outer membrane inhibits entry of these drugs. There are different antibiotics used for different infections. We'll talk about this in this module, but a couple of commonly used drugs to treat gram-negative rods include ceftriaxone, which is a third-generation cephalosporin, or fluoroquinolones like ciprofloxacin. Both of these cover gram-negative rods in many cases. The first bacteria we'll talk about is Klebsiella. This is part of the normal intestinal flora. It's non-motile, which is unusual for a bacteria, and it also has a capsule. People who get sick with Klebsiella typically have impaired host defenses. So alcoholics are a classic group, also diabetics, and also people who are sick in the hospital. These are called nosocomial infections. The illness it usually causes is pulmonary disease, so people aspirate stomach contents and get a Klebsiella infection, either an aspiration pneumonia or a lung abscess. Klebsiella is often resistant to many antibiotics. There really isn't a particular antibiotic you use. Treatment is often based on susceptibility testing, so you send the bug to the microlab and see what it's susceptible to, and until you get the sensitivity testing back, you often use broad-spectrum antibiotics. So let's talk about the infections that Klebsiella can cause. A Klebsiella pneumonia is a lobar pneumonia, and it classically occurs in alcoholics, sometimes in diabetics, and it's usually after aspiration. So alcoholics have impaired sensation because of the drinking, and then they often pass out and aspirate some of their stomach contents, and this is the mechanism by which they can get Klebsiella into their lungs to get pneumonia. And one unique feature of a Klebsiella pneumonia is that it classically produces a red sputum, described as red currant jelly sputum, and this is what you see in patients with Klebsiella lobar pneumonia. Klebsiella can play a role in lung abscesses. So lung abscesses are more commonly caused by mouth anaerobes. So somebody aspirates some mouth anaerobes and this forms an abscess. Mouth anaerobes include bacteria like Peptostreptococcus, Fusobacterium, and Prevotella. Lung abscesses often have Bacteroides as well. Now Bacteroides is a GI anaerobe, but it's often involved in lung abscesses as well. Klebsiella is less common than all these bacteria, but many lung abscesses are polymicrobial, and Klebsiella is often present as well, especially because many people get lung abscesses after aspiration. It can also happen in an alcoholic who passes out and aspirates. They will get these mouth anaerobes that cause an abscess. They'll also get Bacteroides from their GI tract and Klebsiella, and all those things will sort of mix together to cause this polymicrobial abscess in the lungs. But the first bacteria you should think of when you hear of a lung abscess are the anaerobes in the mouth, and those are those first three I've listed right here. Klebsiella is a rare cause of urinary tract infections, and finally it sometimes causes liver abscesses. This is usually in patients who have underlying liver disease or cholangitis. The Klebsiella ascends to the liver and forms an abscess. The next bacteria is E. coli, and you may know that E. coli is a normal colonic bacteria. Most strains of E. coli are not pathogenic, but there are some that can cause disease. E. coli have two special virulence factors that you should be aware of. Some E. coli have fimbriae or pili. If you look at this picture down here on the bottom right side of the screen, you will see that this E. coli has lots of these wispy things sticking out from the side of the bacterial cell. These are the pili or fimbriae, and these can attach to epithelial surfaces, and they may be specialized for certain surfaces like the urinary tract, and this may be how E. coli attaches and ascends in the urinary tract. Another important virulence factor is the K capsule or K antigen. So not all E. coli are encapsulated, but some are. And in particular, there are some strains that have a capsule and have something called the K1 capsular antigen present in that capsule. And these tend to be the most pathogenic strains. About 75% of the E. coli that cause meningitis in babies have this K1 capsular antigen present in the capsule of the bacteria. And it's been shown that the K1 antigen can inhibit phagocytosis and block complement and generally allow the bacteria to evade destruction by the immune system. E. coli causes a number of diseases you should know about. It can cause a watery diarrhea. Some strains will cause a bloody diarrhea, which is also called dysentery. E. coli is one of the most common causes of urinary tract infections and pyelonephritis, and sometimes these urinary infections can spread to the bloodstream and patients can develop E. coli bacteremia or sepsis. You should know that if a patient ever has E. coli in their bloodstream, the most likely source is the urinary tract from a UTI. And then finally, E. coli can cause meningitis in newborn babies. E. coli causes 4 different diarrheal illnesses, and the characteristics of the illness depend on the strain of E. coli that's causing the infection. There is so-called enteroinvasive E. coli, or EIEC. There's enterotoxigenic, or ETEC. There's enteropathogenic E. coli, or EPEC. And then finally, there's enterohemorrhagic, or EHEC. And we're going to talk about all 4 of these different types of diarrheal illnesses. They all have different characteristics that you need to know. Enteroinvasive E. coli invades the intestinal mucosa, just like the name implies. This leads to necrosis and inflammation and a bloody diarrhea, not a watery diarrhea. People describe enteroinvasive E. coli as clinically similar to Shigella because patients infected with both bacteria look similar. But one thing to remember is that enteroinvasive E. coli makes no toxins. Shigella does make a toxin, so don't mix those two things up. Enterotoxigenic E. coli produces 2 toxins, just like the name says, it's toxigenic. They're called heat labile and heat stable toxin, and I talk about these in detail in the module on virulence. These cause a watery diarrhea, classically in people who have traveled to an underdeveloped country and consumed contaminated food or water. So if someone goes to Mexico and comes back with watery diarrhea, what they have is enterotoxigenic E. coli, and there's no inflammation or invasion here. That's why it's a watery diarrhea and not a bloody diarrhea. The next one is enteropathogenic E. coli. This one produces no toxin and also produces no inflammation. It causes blunting of the villi, and this prevents absorption of fluids and gives a watery diarrhea. This usually occurs in children, and this is a big problem in underdeveloped countries where people drink contaminated water. The thing to remember about this is the P is for pediatrics and enteropathogenic because it happens in kids. And then remember here that the problem is really just blunting of the villi in the intestine. It has nothing to do with toxin formation or inflammation. The most complicated form of E. coli to remember is the enterohemorrhagic or EHEC E. coli, and that's because it has a number of special features and it also can cause serious systemic illness. First thing to know about EHEC is that it does not ferment sorbitol. So if you grow it on sorbitol McConkey agar, it will grow as colorless colonies. And I talk about this in more detail in the module on culture. The classic serotype of enterohemorrhagic E. coli is called O157H7, and people often describe this as an O157 infection. This bacteria does not invade the host cells. The disease comes from the toxin. It produces a Shigella-like toxin that leads to bloody diarrhea. And this toxin is carried by a bacteriophage. It's a lysogenic toxin. And I talk about all the features of the toxin in the module on virulence. Usually people get an EHEC infection from eating undercooked beef. And the toxin causes several effects that you need to know in the body. It causes the endothelium to swell. This makes blood vessel lumens narrow. This leads to deposition of fibrin and platelets in the microvasculature, and you end up getting hemolysis and inflammation. And this is what is going to cause the bloody diarrhea in the colon. This is also what's going to cause the systemic toxicities if the toxin makes it into the bloodstream. So the feared complication of this infection is the toxin getting into the bloodstream and causing the hemolytic uremic syndrome, or HUS. This complicates about 10% of EHEC cases, and it's very common in children. So the triad that occurs in hemolytic uremic syndrome is a hemolytic anemia, and remember, those blood vessels are swollen and narrowed, and therefore platelet and fibrates are being deposited, and blood cells are getting destroyed as they try to travel through. All the formation of clots leads to thrombocytopenia, and then the patient gets acute renal failure from destruction of blood vessels in the kidneys, and this causes uremia, which is why it gets the name hemolytic uremic syndrome. There's a related syndrome to hemolytic uremic syndrome called TTP. This stands for thrombotic thrombocytopenic purpura. This is the hemolytic uremic syndrome plus fever and mental status changes. This has been reported after E. coli infections, but usually children who get this just have the hemolytic uremic syndrome. And HUS usually occurs 5 to 7 days after the diarrhea, so the diarrheal illness will occur first, and about a week later they'll start to develop this syndrome. As I said before, if E. coli causes a UTI, it can ascend to cause pyelonephritis, and then it can get into the bloodstream and cause gram-negative sepsis. And sepsis from E. coli or other gram-negative bacteria is a very dangerous condition. These patients will obviously be febrile, they're also tachycardic and often hypotensive. And one high-yield thing to remember, especially for step 1, is that this is driven by the endotoxin in the bacteria. That's the lipopolysaccharide and the lipid A contained in the cell wall of the gram-negative bug. And some common scenarios are an elderly patient who has a urinary tract infection. Maybe they had a catheter inserted in the hospital, or maybe they have prostatic hypertrophy so that they have poor urine flow, and then they develop gram-negative sepsis with blood cultures showing gram-negative bacteremia. This is often from a UTI that's gotten into the bloodstream, and it's often from E. coli. This is a good point to stop and summarize a few points about infectious diarrhea. So there are many, many causes of infectious diarrhea, but in general, you can think of them as the causes of bloody diarrhea or watery diarrhea. When you send stool samples to the lab, these are some of the findings that you can see summarized on the bottom of this slide. If you see fecal leukocytes and red blood cells, this usually means you have an invasive infection. That's what these bloody diarrhea bugs tend to cause. If you see mucus and epithelial cells only, then you're probably dealing with a toxin-mediated disease or a virus, and that's what these watery diarrhea bugs tend to do. And then if you see stool, ova, and parasites, this means you have some type of protozoal infection. So the causes of bloody diarrhea include Campylobacter, Salmonella, Shigella, Yersinia, the enteroinvasive E. coli, and then a protozoa infection called entamoeba, and then finally the enterohemorrhagic E. coli. All of these bacteria here invade the mucosa, so it's very easy to remember that because they cause bloody diarrhea. EHEC is unique in that it's not invasive, but it releases a toxin that leads to bloody diarrhea. And then all these bacteria over here generally cause infection by a toxin. They're not invasive, that's where they cause watery diarrhea. So enterotoxigenic E. coli has a toxin that causes disease. Cholera, C. diff, and Clostridium perfringens all have toxins which lead to disease. The viruses generally don't cause invasive disease. And then finally, these two parasites, Cryptosporidium and Giardia, also cause a watery diarrhea. Next gram-negative rod is Enterobacter. This is a very rare cause of nosocomial UTIs, so UTIs in patients in the hospital. And one thing to remember about Enterobacter is that it's resistant to many antibiotics. It has enzymes called extended-spectrum beta-lactamases, and this makes it resistant to most beta-lactam drugs. Can't use penicillins, can't use cephalosporins, can't even use aztreonam. It's often treated with the carbapenem drugs like imipenem and meropenem. So these are so-called big guns of antibiotics, and this is one of the bacteria that they are used for. Citrobacter and Serratia are the two slow lactose-fermenting bacteria, and neither of these are a dominant pathogen for any one particular clinical condition that you need to remember. They're resistant to a lot of antibiotics, just like many of the gram-negative rods. Citrobacter can be found in the normal GI flora, and it sometimes causes gram-negative sepsis, just like some other gram-negative bugs. Serratia is not part of the normal flora. Things to know about Serratia are that it produces these distinctive red colonies. It's one of the pigment-forming bacteria. It makes a red pigment. It's also catalase positive. There have been reports of hospital outbreaks of UTIs and bloodstream infections with Serratia when there was contaminated water or soap or IV solutions. And it can sometimes cause osteomyelitis in IV drug users, so can Pseudomonas. Salmonella is a very important gram-negative rod to know about. There are two general types. Salmonella typhi causes typhoid fever, and then the non-typhoidal strains are ones like Enterica and Enteritidis. And the non-typhoidal strains cause invasive gastroenteritis. So this is going to be nausea, vomiting, cramps, bloody diarrhea. And people usually get salmonella from eating contaminated foods, classically meat, eggs, or poultry, and this is one of the reasons you need to cook your eggs before you eat them, in addition to cooking your meat. Salmonella is a flagellated and motile bacteria. It is encapsulated, and that's why it can disseminate through the blood, and it's the classic cause of osteomyelitis in sickle cell patients because they are functionally asplenic and vulnerable to infections by encapsulated bacteria. It lives in the GI tract of mammals, birds, and reptiles, and this is why it can get into meat and eggs, and this is why you need to cook your meat and eggs. It produces hydrogen sulfide, so if you do a test called the triple sugar iron test, the media will turn black, and this is how you differentiate it from Shigella, and I talk about this in more detail in the module on bacterial identification. It's an invasive bacteria when it causes GI illness, so the strains that cause GI illness invade the GI mucosa and give bloody diarrhea, and the cellular response is largely monocytes. They sometimes ask you about this on step 1. So now let's talk about typhoid fever, which is caused by Salmonella typhi. And this is a relatively uncommon condition. You may never see it clinically, but you definitely need to recognize it in board questions. So some of the symptoms of typhoid fever include fever, like the name implies, and then there's often a headache. And then you often see abdominal pain and diarrhea. And you know that Salmonella is a GI bug, so it makes sense that it would cause some GI symptoms like this. It's not common in the United States. It's common in Asia and Africa and South America. And in a board question, it's almost always going to be someone who's had a recent travel to one of these places. The first classic feature you need to know about is the presence of rose spots. These are faint macules, often described as salmon-colored, but they're light pink or rose-colored, and they occur on the trunk and abdomen. So if you see a traveler who has diarrhea and these types of spots on the trunk and abdomen, you are probably dealing with typhoid fever. The second classic feature is pulse temperature dissociation. So normally when you have a fever, your heart rate goes up. But in typhoid fever, for reasons we don't understand, the pulse gets slow. It's called a relative bradycardia or a pulse temperature dissociation. And then finally, you should know that this bacteria can hide in the gallbladder and form a carrier state. As many as 4% of people in some of these endemic areas are carrying the bacteria around. And chronic infection with Salmonella typhi may be a risk factor for gallbladder carcinoma. Let's talk about diagnosis and treatment of Salmonella infection. So diagnosis is usually by culture. For patients with non-typhoid strains who have gastroenteritis, it's diagnosed from a stool culture. Patients with typhoid fever get the diagnosis made sometimes by stool culture, but often by blood culture as well. If you have one of the non-typhoid strains and you have Salmonella gastroenteritis, the treatment is fluid and electrolytes to replace what's lost in the diarrhea. And then one thing to keep in mind about Salmonella is that there are very few data showing antibiotics are helpful, and in fact some data show it may prolong the illness. In addition, Salmonella is difficult to treat because there's lots of resistance, so antibiotics are only used in severely ill patients. Most people who have a Salmonella gastroenteritis do not receive antibiotics. And antiperistalsis medications like loperamide are contraindicated. A lot of people like to take these for diarrhea, but they can prolong the illness. If you have typhoid fever, this is treated with antibiotics. It's also difficult to treat due to a lot of resistance, but some of the antibiotics that are often used are ceftriaxone and fluoroquinolones, and these are drugs you would think of for treating gram-negative bacteria. And then finally, there is a vaccine for the typhoid version of Salmonella. It's an inactive variant of the bacteria that's given orally, and it's given to people who are traveling to areas where there's a high risk of getting typhoid fever. The next gram-negative rod is Shigella. So in contrast to Salmonella, Shigella is non-motile with no flagella, so it's different from Salmonella. The names rhyme and people often think of them together, but you can think of Salmonella as this swimming bacteria and you can think of Shigella as this relatively fixed bacteria. Shigella invades mucosa cells. It invades the M cells in the Peyer's patches, and it does this in a very unique way. It triggers the cell to ingest it in a variant of endocytosis called macropinocytosis. And once it gets inside the cell, it induces apoptosis. It spreads from cell to cell, so it doesn't spread via the bloodstream like Salmonella. It jumps from one cell to the next, and it releases a toxin called shigatoxin, and I talk about this in the module on virulence. Non-toxic strains have still been shown to cause disease, so invasion of the cells is probably the more important mechanism. And Shigella is famous for the fact that very few bacteria can cause disease. As few as 10 bacteria can make someone sick. For most infections like Salmonella and cholera, you need to ingest thousands of bacteria to get sick. Not so for Shigella. And the cellular response here is largely neutrophils, and that's also in contrast to Salmonella, where the response is largely monocytes, and they like you to know little things like this for step 1. Shigella is not part of the normal GI flora. It's transmitted fecal-orally, and it's common in children, and you can diagnose it by sending stool to the microlab for culture. The treatment is to give fluid and electrolytes because there is a lot of fluid and electrolyte loss from the diarrhea. Antibiotics have been shown to improve symptoms in this case, and they reduce shedding in the stool so that other children won't get sick. This can limit the spread. And the antibiotics that are usually used are ceftriaxone or ciprofloxacin. So before we go on, let's pause here and talk about the differences between Salmonella and Shigella. They're relatively similar bacteria. They're both gram-negative rods, they both cause bloody diarrhea, and they both are invasive. But you need to know some of the differences, especially for step 1, because these are very high yield. So Salmonella produces hydrogen sulfide, and this makes it black on the triple sugar iron media. This is not the case for Shigella, and this is the way you can tell them apart in the microlab. The biopsy sample of a patient with a Salmonella infection will show a monocyte response by the immune system, whereas for Shigella it will show a PMN response. Salmonella spreads hematogenously, so through the bloodstream, and Shigella spreads from cell-to-cell transfer. And remember, it's taken up by the cells through that process of macropinocytosis that's unique to Shigella. Antibiotics are not helpful and are generally not used for Salmonella, but they are used for Shigella. And Salmonella is motile and it has flagella, whereas Shigella is not. And then two unique features of Shigella are Shigella makes Shiga toxin, and Shigella, remember, is famous for that very low infectious dose, just 10 bacteria or so will make you sick. Next gram-negative rod is Proteus, which is a rare cause of UTIs. So Proteus has a unique feature called a swarm phenotype. So these bacteria have long flagella, which facilitate their ascent in the urinary tract, and this gives them a bullseye when you grow them on agar plates. So what happens is you plate some Proteus on an agar plate and it will swarm outwards and create a circle of bacteria. And then the bacteria will stop and temporarily enter a vegetative state, and then they will return to the swarming state and go out again and make another circle. And it will do this over and over again. So after you've grown it for a while, you'll see this bullseye pattern on a plate, and that's characteristic of the swarming phenotype of Proteus. Proteus also produces urease, and this converts urea to ammonia, and it's associated with struvite kidney stones. And I talk about this in detail in the renal module on kidney stones. The next gram-negative rod is a very important bacteria called Pseudomonas aeruginosa. This is a highly feared bacteria because it causes serious hospital-acquired infections. For example, patients in the ICU often get ventilator-acquired pneumonias, and this is often caused by Pseudomonas, and they can get very sick from this. In addition, Pseudomonas is resistant to many antibiotics. In fact, the drugs that cover this bacteria are often called anti-pseudomonal antibiotics. Causes many types of infections, including pneumonia, as I said, nosocomial pneumonia, urinary tract infections, surgical wound infections. It can cause bacteremia and sepsis. It can cause osteomyelitis, classically in IV drug users. And then finally, the one sort of benign infection it causes is otitis externa, which is an external swimmer's ear infection. We'll talk about that in a minute. So some general characteristics of Pseudomonas. It's an obligate aerobe and it loves the water. It's commonly found in environmental water sources. It's one of the pigment-producing bacteria. It makes a blue-green pigment called pyocyanin, and it will grow smooth fluorescent green colonies on culture media. I discussed this in the module on culture. It also has a sweet grape-like smell when it grows. Pseudomonas contains endotoxin, which is lipopolysaccharide, and this can lead to fever and shock. It also secretes a toxin called exotoxin A, and I talk about this in detail in the module on virulence, but exotoxin A inactivates elongation factor 2, and elongation factor 2 is necessary for protein synthesis. So now let's go through the many infections that Pseudomonas causes. First of all, it can cause pneumonia in cystic fibrosis patients. It's the classic bacteria to do this. It is also the classic bacteria to cause infections in patients who have burns. So they're in the hospital and they've lost their skin defense to infection, and they can acquire Pseudomonas. It classically causes something called hot tub folliculitis. So remember that it loves the water, so it's going to be present in the water in hot tubs. And people who've gone in a hot tub or spa will get tender, itchy papules all over their skin, and this is from Pseudomonas infection. People who've gone swimming can get otitis externa or swimmer's ear. Again, remember this bacteria loves the water, so they get inflammation of the outer ear and the ear canal, and they will present with a painful ear with whitish discharge after having gone swimming, usually in a lake or stream. It's a classic bacteria to cause osteomyelitis in people who are IV drug users. And then finally, it can cause a rare condition called eczema gangrenosum. These are black necrotic ulcers on the skin that happen in patients who are bacteremic with Pseudomonas. It happens because there's invasion and destruction of blood vessels by the bacteria. So the classic case is a neutropenic cancer patient who is in the hospital and therefore acquires this hospital-acquired bug and gets fevers, chills from bacteremia, and then gets black lesions on their chest or back. This is because of Pseudomonas infection, and this is what's called eczema gangrenosum. Before we move on, let me mention a very rare pathogen that's closely related to Pseudomonas. Its name is Burkholderia cepacia, and in fact, people used to think it was a species of Pseudomonas, but it's now been identified as its own bacteria, and in fact, there are a number of subspecies of Burkholderia. These are all gram-negative rods similar to Pseudomonas, and just like Pseudomonas, they are oxidase and catalase positive. Also, just like Pseudomonas, they are a rare cause of cystic fibrosis infections and also infections in people who have chronic granulomatous disease. So you can think of this bug as a close cousin to Pseudomonas. It has different features. It's difficult to speciate out from Pseudomonas. And probably the most important thing is just that you've heard of it, so if it comes up in a board question, you recognize the bacteria. Our next gram-negative rod is Helicobacter pylori, and this is a cause of gastritis and ulcers. Usually people present with abdominal pain. This is a very recently identified bacteria. In 1982 it was identified. People used to think that ulcers were not caused by infection until H. pylori was discovered. An important thing to know about H. pylori is that it is urease positive. So this means it can hydrolyze urea to compounds that damage the epithelium. It's part of how it causes infection. It also means it produces ammonium, which is alkaline, and this helps protect the bacteria from the acidic environment in the stomach. In addition, the urease positivity is useful for diagnosis. There's something called the urea breath test. So patients swallow urea with isotopes like carbon-14 and carbon-13 that can be detected. When they exhale, if you detect isotope labeled carbon dioxide in the exhaled breath, it means urea was split by urease. It means there's urease present, and this suggests that H. pylori is present. So not all ulcers are associated with H. pylori infection, but many of them are. It's very common in patients with duodenal ulcers. Most patients who have an ulcer in their duodenum have H. pylori infection, and some or many patients who have gastric ulcers also have H. pylori infection. It's very high yield to know that H. pylori is associated with something called MALT lymphoma. So MALT stands for mucosal associated lymphoid tissues. This is a B-cell cancer of the stomach, and it almost always occurs in people who have an H. pylori infection. You can diagnose this by taking a biopsy of the ulcer, by the urea breath test, and then there's also a stool antigen test for diagnosis. The treatment for H. pylori is something called the triple therapy for about a week to 10 days. It's therapy with a proton pump inhibitor plus the antibiotic clarithromycin plus another antibiotic, either amoxicillin or metronidazole. And this has been shown to be the most effective to eradicate the bacteria and then let the ulcers heal. Testing is often repeated to confirm eradication, so you might repeat the breath test or the stool antigen, or may even do another scope looking for a biopsy to see if the bacteria is gone. And there are a lot of treatment failures, and there are a whole bunch of regimens out there for patients who have failed the traditional therapies. Next gram-negative rod is Legionella. So it's a gram-negative rod like all the bugs in this module, but it does not gram stain well. There are silver stains that are usually used to visualize Legionella. It has special culture requirements. There is a growth medium called buffered charcoal yeast extract, or BCYE, that is used. This has iron and cysteine added to help Legionella grow, and then it's supplemented with antibiotics and silver dyes. The antibiotics prevent overgrowth by other bugs, and then remember that silver dyes are always good for Legionella. They give it a distinctive color so you can see it under the microscope. It gets its name because it was first identified at an American Legion convention. You get infection from inhaling aerosolized bacteria, so it's not airborne. It has to be aerosolized and come from contaminated water. So there are often outbreaks at hotels where water in the cooling or air conditioning system or heating system gets contaminated with Legionella. It can also cause nosocomial pneumonia outbreaks in nursing homes, and it's very important to culture and identify Legionella because of the fact that it can cause outbreaks. The symptoms begin as mild pneumonia symptoms like fever and a productive cough, but it can progress to become a severe pneumonia, especially if there are outbreaks in a nursing home where people may be elderly and frail. Two unique features of Legionella include GI symptoms. This is very uncommon in patients who have pneumonia. So Legionella patients can get watery diarrhea with nausea, vomiting, abdominal pain. And then also patients with Legionella classically get hyponatremia. So remember, normal sodium is close to 140 or so. Under 130 is very low. This can happen with any pneumonia, but it's very common or more common in patients who have Legionella infection. So the classic case is someone who has a mild cough with watery diarrhea, and then they get confusion from the low sodium, and then they may have no bacteria on gram stain because, remember, it's poorly visualized. And it's treated with fluoroquinolones or macrolides, and these are both antibiotics used to cover atypical bacteria that cause pneumonia, and Legionella is one of the atypical bacteria causes. Pontiac fever is a mild form of Legionella infection, and it's named for Pontiac, Michigan, where the first outbreak was identified. These patients have sort of a flu-like illness, fever, malaise, chills, maybe a headache, and they're tired. They usually don't have pneumonia and respiratory complaints, and they usually have a normal chest x-ray. The final bacteria we'll discuss is Bacteroides fragilis. So this is a gram-negative rod, and it's very important to remember that this is an anaerobic bacteria. So just like all anaerobic bacteria, it likes to cause abscesses when there's a breach of the mucosal barrier. It is part of the normal GI flora. It's rare for Bacteroides to cause infections alone, but it's usually part of polymicrobial infections that start in the GI tract. So for example, patients who have peritonitis following perforation often have Bacteroides involved. People with intra-abdominal abscesses, for example, people who have diverticulitis can have small abscesses at the end of a diverticulum. B. fragilis is usually involved there. Alcoholics who aspirate stomach contents often have Bacteroides present in their lung abscesses. And E. coli and gram-negative rods are often present together in these infections that come from the GI tract. It's covered by metronidazole, so remember that metronidazole is the antibiotic of choice for anaerobes below the diaphragm, and Bacteroides definitely counts as an anaerobe below the diaphragm. And a commonly used combination therapy for gastrointestinal infections is ciproflagyl. So cipro means ciprofloxacin, which is a quinolone, and this is administered to cover E. coli and other enteric gram-negative bacteria. And flagyl is metronidazole, which is given to cover Bacteroides fragilis. And that concludes our module on gram-negative rods.